The day, I'm going to give you low-tech, old stuff. And the reason I'm going to do that is because I'm a clinician, I'm not a researcher. And speaking for the clinicians, we have a problem. And the problem is this. A patient walks into my office, if he's fortunate enough to walk, and he presents with clinical symptomatology consistent with the diagnosis of CRPS. So I take a history and I do a physical examination, and I come to the conclusion that that's an accurate diagnosis. Problem is, nobody believes me. You know, the doctors, 4.3 and all, that have treated this person, they're not going to believe me, simply because that would mean they're wrong. The insurance company, well, they're certainly not going to believe me, because that means they're going to have a chronic pain patient that they have to pay for. And the doctors that the insurance companies hire, well, they don't believe anybody, because they're in the business of saying we're all wrong. So what I need to practice my trade, and in order to be able to get that patient help, and tomorrow there's going to be mention of compensation in order to get paid, is objective evidence. I need something that someone can look at and say, yep, you're right, there it is, there's a picture, that's what it is. And so, how do I do that? Well, I can't do it with any of these tests, simply because they're anatomic studies, and despite the fact that bone scans have enjoyed an amount of notoriety as being the quote-unquote gold standard for the diagnosis of CRPS, I've seen about 100 bone scans. I've seen 3 reported to be abnormal, and maybe 4 more that should have been reported that way. Well, that's 7 out of 100 in my life. So I'm not going to give a patient a radionuclide dye. I'm not going to stick a needle in the arm of an RSD patient. I'm not going to give the insurance company the opportunity to say, see, you're wrong, that test is normal, by doing that. So what do I have? Well, I've got physiologic studies, except EMG and nerve conduction studies measure motor function, so that doesn't work. Evoked potential testing gives me very little information, and there aren't too many studies or reports on QST or AST testing. So what I've got is thermography or infrared imaging, which, as I said, is old because it's been around for 50 years. Now, in point of fact, the idea that heat is consistent with disease goes back to 480 BC and 1957, at least in the modern world. These are the way that thermography has been used. Dr. Lawson in 1957 studied breast disease and really brought thermography into the medical community. So in 1972, and I give you this information because one of the great claims is, well, this isn't covered, this experimental, the insurance company won't pay for it. So you have to understand what has happened, at least in my life, that led up to this. In 1972, the Department of Health, Education, and Welfare said that in all of these disorders, thermography was a valid diagnostic test, the last one being musculoskeletal injury. In 1982, it was permitted to be used as the established test under the Bureau of Medical Devices, which said it's beyond the experimental stage. Now, I started doing thermography in 1982, and it actually was coincidental because in 1982, when this happened, all these companies came out and marketed thermography equipment. So in 1983, the government, and God bless those folks, came along and said, well, we don't think thermography works. So they commissioned a study. And I think you have to hear about this study. They took this study, and what they did was they got patients with disease, and they got radiologists to do radiographs, and they got surgeons to do surgery, and they got a couple of guys off the street to read thermographic images. Now, I say that with tongue in cheek, but that's pretty much what happened, because one of the keys to thermal imaging is quality control. Dr. Moskowitz and I talked about this earlier. If there's a downside to thermography, it's that it takes a lot of time and trouble to do. You've got to have a room that's 68 degrees. It has to be free of ambient light. It has to be free of draft. You have to have a technician who knows what he or she's doing. You have to have a great number of quality controls. They had none. And so the government issued a paper that says, we're withdrawing our position because we did this study and it doesn't work. Well, a bunch of us in thermography wrote a lot of letters, and in 1983, they withdrew their position. And they said, well, now where we are is we don't have a position, which sounds so much like the way the government is anyhow. So the AMA says, we have no position, and they realized that what they had done was wrong. So when I started, they gave me this list. This is what thermography can do. And I'm looking at this thing and say, this is great. You know, this is the second coming of chocolate. This does everything. Look at all these things that I can do with this one piece of equipment. I can do all these really great things. And so my compatriots went out and started doing all of these things. And when they did all of these things, what happened was that along came the American College of Radiology, the American College of Neurology, the American College of Electrodiagnosticians, and said, wait a minute, it doesn't really do those things. And they were right, because it really does all of these things, some of them very poorly. But what it does very well is breast health and reflex sympathetic dystrophy, or today complex regional pain syndrome. And this one, thoracic outlet syndrome, because of the real-time capabilities of today's cameras. So we backpedaled a little bit and we started saying, okay, we're going to limit what we're doing thermographically to just those three things. And I've done thousands and thousands of patients only doing those three things. So why use infrared? Well, I learned today at lunch, it was a very educational lunch, I learned today at lunch that the second most measured thing in the world is temperature. First most measured is time. And I got this from an expert who I was sitting across the table, and he was explaining this to me. But infrared image records the body's heat. We all give off heat. And the fundamental concept of thermography is that the body is a symmetrical entity. The left side of your body and the right side of your body are mirror images of one another, within reason. And within reason is the parameters that we of the thermographic community have identified and use. So physiologically, we have a diagnostic test that works on physiology that measures sensory sympathetic dysfunction. Geez, we got a disease that's a sensory sympathetic dysfunction disease. So for me, this is a square peg in a square hole. And the anatomical tests give me nothing more than telling me what isn't wrong with the patient or what is a contributing cause to the patient. So I'm using physiologic infrared to measure for the patients. And really, all I'm doing is going 5 to 6 millimeters in depth, and I'm measuring microdermal skin blood flow. Because the microdermal skin blood flow with today's technology is actually measuring hyperthermia or hypothermia. And it doesn't matter how deep it is, because that heat or lack thereof is transmitted to the skin surface, so we can measure this. Physiologically, we have the largest organ of the body, which is the skin. The autonomic nervous system controls the changes in the diameter of the vessels. When they fill, they get hotter. When they don't, they get colder. And it really is simplistic. Now, in a day where we've talked about stuff that I've listened to and I don't understand, okay, this is simple stuff. This is old, fundamental, simple, rudimentary stuff that works. So hyperthermia comes from this list. So if you do a thermogram on a patient with a new complex regional pain syndrome and you have an acute nerve irritation, you've got a hot entity, limb, whatever it happens to be. If it's not, sympathetic stimulation causes it to be cold. And that time frame thermographically is about 6 months. And so what I'm looking for is asymmetry. I'm looking for the opportunity to look at a patient who has a provisional diagnosis of complex regional pain syndrome and say, here's where it is. And what I have found, which I will tell you shortly, is really rather fascinating. So the benefit of thermal imaging is we can image the function of the nervous system, especially in chronic conditions. We can determine by heat or cold, coupling it with a history or physical examination, the presence or absence of sympathetic dysfunction. I can take this piece of information, and armed with this piece of information, I can convince people, doctors, insurance companies, lawyers, whatever it has to be, that I'm actually going in the right path treating this patient. I'm not treating anybody with infrared. I'm using this as a diagnostic tool. You know, we've talked about conventional MRIs. Someone mentioned earlier, you have a disc bulge on one side and symptoms on the other side. And so you have a mismatch. I have now a patient who has sympathetic dysfunction, signs and symptoms in a limb, and that limb is showing up thermographically abnormal. I've got a match. And now I can proceed to do what needs to be done, and I can monitor the way that that treatment works. Because if it is sympathetically dependent pain and someone gets a sympathetic blockade, a cold limb should get warm. To that end, we are working with interventional pain specialists using this as a diagnostic tool in real time to permanently insert spinal cord stimulators. Because remember, when you put a spinal cord stimulator in, what are you doing? You've got a patient that's awake saying, tell me what you feel. And then you implant this device, hoping that you haven't moved it a millimeter here or a millimeter there and losing the capabilities to the maximum degree of that stimulator, whereas in real time, I've got a camera that I can focus on a limb and watch it go from blue to red and know that it's in the right place. So I can take the human portion of it out, and I don't have to have that patient telling me what he or she is feeling or what he or she thinks we may want to hear. And so in CRPS, we have excessive vasoconstriction of blood vessels that cause cold hands and feet, and because of those changes, I can pick them up thermographically. So what we have is thermal patterns. We don't have dermatomal patterns, we have thermotomal patterns. We have patterns of circulation that will give me asymmetry left to right or in adjacent body surfaces. It is illogical to think that the index finger will be 36 centigrade degrees and the palm of the hand will be 28. It's illogical because it simply doesn't exist in the real world. And while you could make the argument that there is a vascular problem, again, we're using this as a part of our diagnostic armamentarium. We're using history and physical examination coupled with the thermal mapping to give us what we're looking for. And so I will tell you that there are over 800 peer-reviewed articles that have been written about thermography over the course of the last 50 years. So all the claims, well, it's not this, it's not that, it's this. In this country, we use very little thermography because of the study, because of the fact that there's so much medical politics, and I'm not going to belabor that point. I will tell you that in Brazil and in Germany and Great Britain, in Japan, in Poland, the list goes on and on. This is a diagnostic tool that's being used far more than we use it here, and it's being used for a reason. It's simple, it's not invasive, it's cost effective. You can buy a thermographic system, soup to nuts, right now for less than $30,000. It's easy. And when I show you the pictures, if you've never seen an infrared image before, what you're going to see is the ability to perceive something and recognize the lack of asymmetry. Now, the purpose of me being here today above and beyond this, other than to give you the old view as opposed to all the new views, is we're measuring neuroinflammation in its most rudimentary fashion. We have a diagnostic test that we can show patients and help them understand and be proactive in their own health concerns. But what I found out over the last several years, interestingly enough, is in addition to the fact that having done over probably 300 or 400 patients with this neuromuscular, in a neuromuscular fashion, I found out that this diagnostic test for me has a predictive value. Now, what do I mean? Well, if someone comes in with arm symptoms, I don't just do the arm, I do the entirety of the body. And I follow the protocol which says not only do I do it once, I do it twice. And here's what I found. What I found was that a patient comes in with an injury, and the injury gives them thermal abnormalities. I know it gives them thermal abnormalities. And the thermal, I should be able to do this. Okay, well. Like I said, it's old stuff. The thermal abnormalities really are evident in the back of the left foot and ankle. And so I'm able to measure the temperature gradient from the circles are mine, and I'm able to measure the temperature gradient. And there's subtle changes through here. And this patient comes in and says, I've got a bad foot, and the history is consistent with a left lower extremity complex regional pain syndrome. And I say, great, and I go ahead and I do the thermographic study, and I find this. This is the same patient. And what I find is that the patient's left hand, for whatever reason, there's fingers missing. Now, those fingers aren't missing, obviously. They're just so cold they've dropped off the palate. But the point is that this patient has no symptoms in the hand. The symptoms are limited to that foot. There's nothing else. I'm asking a million questions. There's nothing there in the hand. But I've got thermographic evidence. I've got a patient that's got a problem with the hands. This is the upside down. This is the left arm. This is the right. Now, if you've never seen a thermogram before, this one's supposed to look like this one, and it doesn't. And so I get this. Same thing, left leg, right leg, and I'm saying to myself, you know, there's something going on here. Now, this opens up a wonderful possibility for me, and it's two possibilities. One is diagnostic, and the other is real world. Okay, because I'm not sure that I really live in the real world, but I like to think that I do. In the real world, imagine, if you will, if I take this patient who presents with this, and I say to this patient, you know what, I'm going to give you, and I don't do this, but I'm going to give you a lumbar sympathetic block. And that patient says, well, why are you giving me a lumbar sympathetic block? I don't have anything wrong with my leg. And I say, that's it. I don't want you to have anything wrong with your leg, because I'm going to tell you what, 6 months from now or less, you're going to come back and tell me that you've got pain in that limb. Because every one of the people that you're seeing, and the 9 other people that I've done, and there are 14 in all that I've done this with, every one of the 14 people has had spread of the disease to the limb that was predicted by the thermographic test. And in every one of the cases, the pain and the symptomatology and everything that went along with the complex regional pain syndrome was worse the second limb than it was in the first. So not only does it validate the fact that it spreads, and there's articles about the spread of the disease, but it validates the fact that if we can take this centralized disease and maybe head it off in some fashion, it opens up a whole new world of thought process. How can we prevent this disease from spreading once we identify where it is? Because we've been able to identify where it is. We can identify this in a patient involved in a motor vehicle accident. Now, what made this interesting in this particular case was that the individual in question impacted her knee in a motor vehicle accident. She went to the operating room because of a meniscal tear that was symptomatic. They repaired her meniscal tear. She came out of the operating room and she was fine. And about 3 weeks later, she started to have pain. Magic question, is the pain the same as it was before the surgery? No. How is it different? It's entirely different. How is it different? Well, before it ached, it was sore, I couldn't go up steps. Now it burns. So you now have a whole separate set of issues to deal with. And you get into the medical legality of, did the surgery cause this? And that's really not what this is about. What this is about is the fact that this individual with knee symptoms, limping, also has hand symptoms. And the individual in question here is one of the 5% who spread crossways, because 95% of the disease, as you know, spreads horizontally or vertically. This woman spread from the right leg to the left hand. And this is not small stuff. You know, this kind of temperature gradient, and we allow up to 1 degree centigrade in a differential. That's 4.3 degrees between this hand and this hand. 4.3 centigrade degrees is an incredible amount of difference, and can be nothing else, because if this were vascular, then why is it only vascular in that area? This is clearly not vascular disease. And when you look at the thermal patterns that are consistent with complex regional pain syndrome, you can't mistake them for anything else. They're not vascular in presentation. And then again, neither is the history or physical examination. A little bit more subtle, a little bit of change in the hand, a little bit of change in the little bit of finger. Small stuff, okay? This is the left buttocks and into the left thigh. So what I have found, and it really is anecdotally, because when someone comes in with left hand symptoms, it would make sense to do the left upper body. What I have found is this test is prognosticating the spread of the disease. Now, I understand, because of the dynamics of the insurance world, that nobody is going to let me give somebody a sympathetic block or whatever treatment I choose to render into an unaffected body part. Maybe someday we'll figure out a way financially to do that, but it opens up a whole nother world of possibilities. The point that I'm making here is that when that patient comes in and begins to complain of symptoms, and I'm monitoring it, anything new, anything going on, because I'm seeing these people in a clinical setting on a regular basis, at least I'm getting the spread treated at the earliest possible interventional time. Last one. Okay, so you have an individual with clear thermal asymmetry, vertical spread of the disease. And this is, again, 1.5 degrees, the asymmetry between one side and the other. So the point that I'm making here is that with the clinical need to document, I'm constrained by anatomic testing and physiologic testing of a non-sympathetic, non-sensory nature. And what I need to do is 2 things. Number one, I need to be able to move forward and treat people, and the only way that I can do that at this point in time is to have objective medical evidence. Well, I have objective medical evidence. It's quick, it's easy, it's non-invasive, it's cost-effective, okay? And because I've been doing it for as long as I have, it's done in a proper fashion. The new information, the new technology allows you to take images, and if you say, listen, I'm going to do this in my office, but I don't want to be bothered interpreting these images, I don't want to do this, there's medical legality. Everything now is emailable, everything is overreadable by other people, but this is simple, fundamental technology. Now, for those of you who are doing all of the things that I've heard today, this must seem really, really almost backwards, because it really is low tech, as I said earlier. But I think that for today, this is something that we need. This is something that we have to have for the second reason, which is that if a patient has gone from doctor to doctor, and we know this happens, and they've come in, and this one says this, and this one says that, and they get a third opinion over here, and the fourth one, of course, says there's nothing wrong with you because all your tests are normal, so it must be in your head. We're validating the disease diagnosis. And when you have a patient and you say, I want you to look at this picture, I want you to understand what complex regional pain syndrome means, I want you to understand that's what this picture shows, I want you to understand that I know what's wrong with you and I can help you, okay? I go through lots of tissues in my office because people see this and they get to the point where they say, finally, I have found somebody who at least is going to give me an answer. Now, I'm not telling you we're curing the people, we're making them better. All I'm saying is at least I have a clue that I can prove. So I asked Mark Cooper for the permission to talk to you today, and I thank you for allowing me to do that, because I want you to understand that sometimes older, at least today, is better, because we can do this, we can get this paid for by the insurance industry, we can get this done efficiently, and we can get this done in our own offices. And we don't need the real expensive machines, the real high-tech stuff, which right now we can't get paid for, and becomes something that down the road I'm sure is going to replace this. 5 years from now, I'm sure there's going to be 15 things better than this. But for now, for those of us in clinical practice, at least it gives us an alternative. And it's an alternative that I think we need because for me, in my clinical practice, it solves a problem. It solves the problem of how do I tell the people that are wrong that they were wrong and be able to prove it. It's not about validating my position, it's being able to move forward and help that patient.
First, let me commend you on it. There's a fellow named Nick Diakides. Do you know that name?
Mm-mm.
Nick Diakides has been a champion for this particular technology as part of a larger diagnostic framework. Certainly not as a standalone diagnostic modality,
right.
Because what you heard here today was that there are many very sophisticated diagnostic modalities. The problem is that not everybody can afford them. People can afford this. Nick passed away a couple of years ago. He was an engineer. A lot of the work that he did was really in then taking much of the sophisticated equipment that had for a long time been classified for military use of thermology and thermography, and then taking that declassified information and then operationalizing that to the medical milieu. That's now been done. So the first point you made with regard to the validity of this is very important, because what this is actually doing is contradicting the older AMA report that didn't see the validity or value in thermology, much the same way it would have said that X-ray is totally ridiculous and cannot be used as a diagnostic schema, and then ignoring what positron emission tomography and SPECT is doing, which essentially is built on very much the same technology as X-ray. So number one, you have more sophisticated technology and computational technology. But number two, let me make a suggestion. The argument that will actually get this more thoroughly evaluated by second and third party payers is to avoid the use of the term diagnostic technology and call it an assessment technology. And let me tell you why. When we went to the AMA in 2007 on the charge of what was technology assessment, this was viewed as having a high probability of success as an assessment technology, as part of a diagnostic schema. So to tease apart and do a differential diagnosis that includes other techniques and technologies, this particular technology stood very, very strongly. As a standalone diagnostic, it still carried the burden of stigma of the old AMA report. So although it's something very, very subtle, it's lexical, but it is in fact a sharpening to the point of the spear that you used to use. I congratulate you on your efforts.
Thank you, and I appreciate the heads up, because anything that's going to help me, I'm going to take, to task. There's no question. I mean, obviously it's a passion. You can see the way it is, but if it's going to help me help people, then great.
And there's also a statistical parametric program that can help you with regard to validating these results with regard to quantitative endpoints that's commercially available that only came online a year after. So
then we'll talk. Thank you.
Comment about first a question. Have you correlated this with galvanic skin resistance?
No.
Because in sort of older studies of autonomous nervous system disturbance or lability or instability, that was found, or thermography and galvanic skin resistance has been used a fair bit. And I think, just that was the question. The other thing is, you said you can do a sort of prognostication, and I'm building on what Jim just said. The next step would then be, rather than calling it a diagnostic, would be to do something like staging, disease staging. Because I think that is the first step of showing its utility, and probably showing its utility across board other things like recovery after trauma, other trauma that are not necessarily complex pain syndromes. In the area of psychosis research, people are now trying to get away from diagnostic classification and trying to introduce staging models, because it led to overall a stagnation of the field making these diagnostic claims. So I'm really very emphatically supporting what Jim said.
And I appreciate the
And let me two things. Number one, the comparison to galvanic skin responses in the paper that I'm going to recommend you to is a paper by Conwell et al. And it's in the International Journal of Thermology, 2009. It actually looks at comparators to GSR, and then it also takes that idea and operationalize it with regard to staging for treatment as an assessment paradigm.
Okay.
Very important.
Good, thank you.
I would like to commend you as well on this nice work. We use thermography as one of the tools in diagnosing CRPS. Now, I would like to ask a question of you, because in my experience and opinion, if there is one feature which is variable in CRPS patients, it's temperature. And we did this in CRPS patients, actually measuring 24 hours temperature variation, and it's all over the charts. It goes from cold to warm to cold to warm. So that's one thing. And there may not be a difference in one assessment. So the point is, shouldn't you be looking perhaps more at a sort of a challenge test, looking at the way the patient reacts to some kind of heat or warm stimulus in order to see what's happening there in there, rather than a fixed assessment of temperature, because of the fact that, well, this changes a lot in these patients, and can go to no difference at all, up to warm, up to cold. It can vary a lot in these patients. So my suggestion would be do repeated measurements to start with. If you do so a single measurement wouldn't be enough. The second thing would be to do a challenge test in order to look how the system responds to temperature variations.
We did we do a cold challenge in breast disease. Obviously, it's off the topic, but there is a tremendous upsurgence of thermographic testing for early stage breast disease, and we've seen reversal of thermographic abnormalities with diet and lifestyle alterations in breast disease. So we're doing a lot of breast thermography. We found trying to do a cold challenge, and we tried to do that on some of the CRPS patients in giving them cold or ice or something like this. And all it did was give them a tremendous amount of pain. But you make a good point. The other thing that I do want to say, however, is I've seen patients, and I've seen lots of them go through this, who come in who say to me, maybe I shouldn't be doing this test today because I'm having a really good day. Okay, my hands aren't burning, my feet aren't cold, whatever, and it doesn't seem to matter, because the underlying changes that I'm seeing, and I'm not saying it's 100% because nothing is, they seem to be there regardless of what the symptom complex is, which to me is another wonder of this. And I think that there's a lot of untapped information, despite the fact that people have been doing this for 50 years. The technology, and which is what you're talking about, the technology is so much better now than it was even 5 years ago in terms of the cameras and the computerization of data, that I think as we move forward, we're going to get more information.